Hello, students. It's Dr. Shafia here, and the topic which I'm going to discuss today is general anesthetics. Before starting the main topic, I would like to outline the basic objectives of this topic. In this lecture, we will discuss about the general anesthesia, ideal anesthetic, and the balanced anesthesia. What are the various stages of anesthesia, anesthesia protocols, classification of general anesthetics, their mechanisms of action, and details about the intravenous and inhaled anesthetics. Now, first of all, what is general anesthesia? General anesthesia is a state typically characterized by analgesia, amnesia, loss of consciousness, inhibition of reflexes, and skeletal muscle relaxation. The drugs which are used as general anesthetics are basically CNS depressants, which have the actions that can be induced and terminated more rapidly than those of conventional sedative hypnotic drugs. Now, coming towards the characteristics of an ideal anesthetic. An ideal anesthetic is the drug that will induce a smooth and rapid loss of consciousness while allowing for a prompt recovery after its administration is discontinued. Now, what are the various stages of anesthesia? In modern day life, anesthetics which are used act very rapidly and achieve deep anesthesia quickly, while with older and more slowly acting anesthetics, the progressively greater depth of central depression after increasing the dose or time of exposure is traditionally described as the stages of anesthesia. Now, there are four stages of anesthesia. These include first is the stage of analgesia. In this stage, the patient has decreased awareness of pain, sometimes with amnesia. Consciousness may be impaired, but it is not completely lost still. The second stage is the stage of disinhibition. In this stage, the patient appears to be excited. Amnesia occurs, reflexes are enhanced, respiration is typically irregular, and incontinence may occur in this stage. Third is the stage of surgical anesthesia. In this stage, the patient is unconscious and has no pain reflexes. Respiration is very regular and blood pressure is maintained. Fourth and the last stage is the stage of medullary depression. Patient develops severe respiratory and cardiovascular depression in this stage, and that requires mechanical and pharmacological support. Now, what are the various protocols controlling anesthesia practice? The choice of anesthetic technique will vary according to the type of diagnostic, therapeutic, or surgical intervention to be carried out. For minor procedures, conscious sedation technique that combines intravenous agents with local agents are used. While for more extensive procedures, the protocol is different. For extensive procedures, we need different drugs for the induction of in the anesthetic state, the other drugs to maintain that state, and some drugs to achieve the muscle relaxation. Commonly, intravenous drugs are used to induce the anesthetic state, while inhaled anesthetics are used to maintain that state, and neuromuscular blocking agents can cause muscle relaxation. This is called balanced anesthesia, in which a combination of drugs is used to achieve the complete general anesthesia. What are the various types of general anesthetics? There are two types of general anesthetics. One is inhaled anesthetics, the other one is intravenous anesthetics. Initially, only inhaled anesthesia was used for all types of procedures, but recently, intravenous anesthesia has become a more widely used technique around the globe. Now, coming towards the mechanisms of action. Different drugs have different mechanisms of action. Mainly, they may act on by their effects on the ion channels with subsequent effects on central neurotransmitter mechanisms, while some drugs can act by causing inhibition on the GABA receptors, such as barbiturates, benzodiazepines, inhaled anesthetics, propofol, etomidate, and etc. While other drugs such as ketamine can cause the antagonism of glutamic acid on NMDA receptors. The last mechanism is the effect on strychnine sensitive glycine receptor. This receptor is a ligand gated ion channel and it is the main target for certain inhaled anesthetics. Mm. Now we will discuss about the inhaled anesthetics. What is their classification? These include nitrous oxide, halothane, desflurane, enflurane, isoflurane, sevoflurane, and methoxyflurane. As the name indicates, these drugs have their names ending with ane, except the nitrous oxide. Nitrous oxide is the gas form of inhaled anesthetic, while other are in the liquid forms, easily vaporized liquids. These are halogenated hydrocarbons, and their names end with ane, and only nitrous oxide is in gaseous form. Now we will discuss about the various factors which affect the induction of anesthesia. These include the solubility of the drug, inspired gas partial pressure, ventilation rate, pulmonary blood flow, and AV concentration gradient. First of all, how does the solubility affect the induction of anesthesia? The more soluble a drug is, the more rapidly the anesthetic state will be achieved. Next is the inspired gas partial pressure. A high partial pressure results in more rapid achievement of anesthetic levels in the blood, and vice versa. Next is the ventilation rate. The greater the ventilation, the more rapid is the onset of anesthesia. Fourth one is pulmonary blood flow. Pulmonary blood flow has an inverse relationship with the induction of anesthesia. More the pulmonary blood flow, slower is the onset of anesthesia. Last is the AV concentration gradient. While the anesthetic tension is different in arterial and venous blood, while when the soluble drugs are given into highly perfused tissues, it may decrease the gas tension in mixed venous blood. It can influence the rate of onset of anesthesia. Now we will discuss about the elimination of inhaled anesthetics. Anesthesia is terminated by redistribution of drug from brain to blood, and finally it is eliminated via the lungs. The rate of recovery from anesthesia using these agents is faster with the who have low blood gas partition coefficient than those with high blood solubility. Some drugs are also metabolized by liver enzymes. These include halothane and methoxyflurane. The next is the minimum alveolar anesthetic concentration, MAC. MAC value is defined as the alveolar concentration required to eliminate the response to a standardized painful stimulus in 50% of the patient. It is the measure of the potency of inhaled anesthetics. MAC values for infants and elderly patients are lower than those for adolescents and young adults, while when several agents are used simultaneously, their MAC values are additive. What are the effects of inhaled anesthetics on different organ systems? First of all, we will discuss about their CNS effects. In CNS, inhaled anesthetics decrease the brain metabolic rate, they reduce the vascular resistance, and thus increase the cerebral blood flow. This may lead to increased intracranial pressure. Now, what are their effects on cardiovascular system? Most inhaled anesthetics decrease the arterial blood pressure, and fluorine and halothane are myocardial depressants that decrease the cardiac output, while as isoflurane, desflurane, and sevoflurane cause peripheral vasodilation. Next is the respiratory effects. Although the rate of respiration may be increased, all inhaled anesthetics cause a dose dependent increase in tidal volume and minute ventilation. Most inhaled anesthetics are bronchodilators, but desflurane is a pulmonary irritant and it may cause bronchospasm. That is the difference that must be remembered. All the most inhaled anesthetics are bronchodilators, but desflurane is not. It can cause bronchospasm. Next is the renal effects. Depending on the concentrations, these anesthetics decrease the GFR and renal blood flow, but increase the filtration fraction. They have their effects on liver also. but these effects are only transient. No permanent changes are observed yet. A concentration dependent decrease in hepatic blood flow can occur with their use. Effects on uterine smooth muscles. In case of uterine smooth muscle, only nitric oxide appears to have little effect on uterine musculature, and this pharmacological effect can be used to advantage when profound uterine relaxation is required. For example, when we need the uterine relaxation for any intrauterine fetal manipulation or manual extraction of retained placenta during delivery, then this effect of nitrous oxide can prove to be beneficial. But it can also lead to increased uterine bleeding. As the musculature is relaxed, then bleeding can increase. What are the toxic effects of inhaled anesthetics? Every drug has its own pros and cons. Now, in case of inhaled anesthetics, the toxic effects include hepatotoxicity, nephrotoxicity, megaloblastic anemia. Megaloblastic anemia can occur with the use of nitrous oxide for prolonged period. And malignant hyperthermia can also occur. Muscular spasm and autonomic lability can occur with that. For malignant hyperthermia, dantrolene is the drug of choice for treatment. What are the clinical use of inhaled anesthetics? These anesthetic drugs are rarely used as sole agents, both for induction and maintenance of anesthesia. Only they are used alone in children for the induction of anesthesia, while in all other age groups, they are used in combination with the other intravenous agents in the form of balanced anesthesia. Among inhaled anesthetics, nitrous oxide, desflurane, isoflurane, and sevoflurane are the drugs that are most commonly used. Use of less soluble agents has increased as more surgical procedures are carried out on ambulatory basis. Ambulatory basis mean those surgeries which require short hospital stay. In those cases, less soluble agents are used because their recovery is faster than those of more soluble agents. Now we will discuss about the intravenous anesthetics. Intravenous anesthetics include barbiturates, benzodiazepines, ketamine, opioids, propofol, and etomidate. All of these are central nervous system depressant drugs. First of all, barbiturates. Barbiturates include thiopental and methohexital. These two drugs have high lipid solubility, which promotes their rapid entry into the brain and results in surgical anesthesia in one circulation time, that is less than 1 minute. They have a fastest onset of action. They are used for induction of anesthesia and for short surgical procedures. Their anesthetic effects are terminated by redistribution, but hepatic metabolism is necessary for their complete elimination from the body. Barbiturates are respiratory and circulatory depressants. Because they depress the cerebral blood flow, they can also decrease the ICP, that is intracranial pressure. Next group is the benzodiazepines. Among benzodiazepines, midazolam is a widely used drug. It is used in combination with inhaled anesthetics and intravenous opioids. It has slower onset but has longer duration of action. Flumazenil can be used to reverse the postoperative respiratory depression which can occur with the use of benzodiazepine. In this case, flumazenil is the antidote. Next is the ketamine. Ketamine is the drug which produces a state of dissociative anesthesia. Now, what is dissociative anesthesia? It is the state of anesthesia in which the patient remains conscious but has marked catatonia and analgesia and amnesia. Catatonia is the state of immobility in which the patient is conscious but cannot move. And analgesia is loss of pain and amnesia is loss of memory. Ketamine can lead to an increase in intracranial pressure. This drug is a cardiovascular stimulant and so, uh, it can cause and raise in ICP. While its toxic reactions include disorientation, excitation, and hallucinations, which can occur during the recovery from ketamine anesthesia, and these effects can be reduced by the preoperative use of benzodiazepines. So, ketamine is used along with benzodiazepines. Next group is the opioids. Among opioids, morphine and fentanyl are used with other CNS depressants, especially in those patients who are at high risk and cannot survive a full general anesthetic drug. IV opioids may also cause the chest wall rigidity and respiratory depression. And L-fentanyl and remifentanil may be used for the induction of anesthesia. While next group is the propofol. Propofol is the drug which has rapid onset and rapid recovery. It is commonly used as a component of balanced anesthesia and as an anesthetic in outpatient surgery. Outpatient surgery is that surgery in which the patient is not required to stay in the hospital and he is immediately discharged after his surgery. For this purpose, we can use propofol because it has rapid onset and rapid recovery, and there are no after effects. It can cause marked hypertension via decreased peripheral resistance if it is used for prolonged period of time. And Fospropofol is the water-soluble prodrug form of propofol, and it is rapidly broken down in the body and more readily injectable and appears to cause less pain at injection sites than the standard form of the drug. So, fospropofol is useful, more useful than the propofol. Last group is the etomidate. Etomidate is an imidazole derivative which has rapid induction with minimal change in cardiac and respiratory function, and it has short duration of action. It is not analgesic, but the basic advantage in the case of etomidate is that it is useful for those patients which have limited cardiac or respiratory reserve. Those patients which are going through any cardiac or respiratory dysfunction, in such patients, etomidate is of more use as compared to other intravenous agents. But its prolonged administration can cause adrenal suppression. This is enough for today. I hope you can now understand the importance of general anesthesia in today's clinical practice and their classification and various drugs which can be used to induce the general anesthesia and its maintenance. And that's all for today. Thank you so much.